Dear students, let me take up today a topic which is of a good importance, that is sensory neural hearing loss. Sensory neural hearing loss is different from conductive hearing loss. We know very well how to differentiate between these two. Conductive hearing loss is one which is resulting from the problem anywhere from the external canal up to the inner ear. That means external canal and middle ear cavity up to the stapediovestibular joint. Beyond that, that is any pathology in the inner ear or pathology in the auditory nerve will produce sensory neural hearing loss. How do we know clinically? Clinically, we can subject the individual for tuning fork test, which is very basic, and audiogram. Tuning fork tests, they are qualitative and semi-quantitative as far as the hearing loss is concerned. Now, with tuning forks, how do we know patient is having what type of deafness? We vibrate a tuning fork, preferably 512 or even 256, and put over the just lateral to the auricle, and then we transfer to the mastoid process. This is release test. Air conduction is better than bone conduction, that is release positive. Release positive will be positive in health and nerve deafness or sensory neural deafness, otherwise known as. Whereas bone conduction is better than air conduction in conductive deafness. Now, how to know which ear is the affected ear or which ear is more affected than the other? We do Weber's test. That is, vibrate the tuning fork and put at the center of the forehead, glabellum. Now ask the patient which ear is better head. This is called Weber's test. So Weber's test will be lateralized in the poorer ear in case of conductive deafness, better ear in case of sensory neural hearing loss. So with this we will know how to diagnose sensory neural hearing loss. And if you subject the individual for pure tone audiometry, both air conduction and bone conduction will be decreased in case of pure tone, in case of sensory neural hearing loss. Whereas in conductive deafness, there will be air-bone gap. That is, bone conduction will be normal, air conduction will be dropped. Now, in comparison to the conductive deafness, sensory neural hearing loss poses greater difficulty for the patient because it produces distortion of the sounds or speech. The higher frequencies will be more affected in case of sensory neural deafness, and there will be difficulty for hearing consonants. Consonants form the important feature in speech. So, if consonants are not heard, there will be difficulty in hearing speech. Not only that, in sensory neural deafness, there will be what is known as loudness recruitment. What is recruitment? Recruitment is a phenomenon where soft sounds will not be heard, loud sounds will be heard louder than normal, because in recruitment what happens is there will be loss of hair cells, especially the outer hair cells. Outer hair cells will take care of the higher frequencies, and inner hair cells will take care of the lower frequencies. Now, say in case of Meniere disease or ototoxicity, the inner hair cells will be affected. So, when cochlea is stimulated, as inner hair cells are affected, outer hair cells will take their function. As a result, what happens? Lower intensity sounds are not heard, higher intensity sounds are heard, but heard more than normal, because outer hair cells have been recruited. This particular phenomenon will give rise to discomfort of the patient who is suffering from sensorineural hearing loss. In daily life, you must have observed, if you talk to a sensorineural hearing loss patient, he'll be objecting to you. Why are you shouting? Speak slowly. That's what we always tell you. Now, not only that, in case of neural deafness, especially, that means if the nerve is involved, there will be loss of speech discrimination. That means recognition of speech. So these are the difficulties that are posed in case of sensorineural deafness when compared to the conductive deafness. Now, how sensorineural deafness results? The causes are viral infections. First and foremost is mumps. Mumps is a viral infection affecting predominantly the salivary glands. Apart from salivary glands, it will also involve the male and female genitalia. That is why mumps affected individuals may have orchitis, and subsequently they may have azoospermia and infertility. Coming back to the mumps producing sensorineural deafness, mumps patient will have high fever with parotid swelling. So these individuals may develop sensorineural hearing loss, predominantly unilateral. Next is the measles. Measles, there will be infection spreading from subarachnoid space to the cochlea through cochlear aqueduct. So cochlear aqueduct, it traverses from the membranous labyrinth and ends at in the subarachnoid space near the jugular foramen. Now, if the infection is there in the blood, that reaches the cochlear aqueduct, and through that it enters the subarachnoid, it enters the cochlea and produce damage to the cochlea and produce nerve deafness. And ordinary influenza also can produce nerve deafness, sensorineural hearing loss, and it may also produce myelinitis, bullosa, hemorrhagica. As the word implies, there will be inflammation of the tympanic membrane characterized by bullous lesions, which occasionally produce slight bleeding. Next is Ramsay-Hunt syndrome. Ramsay-Hunt syndrome is otherwise known as geniculate headpiece, wherein there will be conductive deafness, there will be sensory hearing loss, vertigo, and vesicular lesions at the mouth of the extrauditive canal. Next, certain bacterial infections, especially chronic suppurative otitis media, producing suppurative labyrinthitis. Suppurative labyrinthitis, it will invariably produce hearing loss. Not only that, even serous labyrinthitis also will may produce sensory hearing loss. And last but not the least, meningitis. If meningitis, bacterial meningitis is neglected, invariably it will produce sensorineural hearing loss. How it produces? The meningitis will produce what is known as labyrinthitis ossificans. That means the entire labyrinth, membranous labyrinth, that is the various thirds of cochlea, semicircular canals, they are all replaced by bone, and patient will suffer from sensorineural hearing loss. Syphilis is very notorious in producing sensorineural hearing loss. Thank God it is not seen nowadays, but we should keep in mind there might be a case or two somewhere, and more due to congenital syphilis than acquired syphilis, individuals may suffer from sensory hearing loss because of the osteitis of the bony aortic capsule. Generally, it is bilateral, and you may see Henbert sign, that is vertigo due to fistula sign. That is what a fistula sign positive without actual fistula being present because of the stapediovestibular joint dysfunction. There will be absence of angular ligament of the stapediovestibular joint. That is why if you apply gentle pressure, the footplate of stapes will be moved inward and the labyrinth is stimulated. Now, the treatment is by penicillin, about 5 lakhs units, hourly, along with steroids. Last but not the least, the presbyocusis. Presbyocusis is nothing but senile deafness or deafness related to aging. Pres means aging. Presbyopia, that means senile blindness or senile diminution of the vision. And there will be, what happens in presbyocusis? There will be degeneration of the inner ear organs, especially the stria. If there is degeneration of the stria vascularis, the audiogram will be flat, but there will be good speech discrimination. But if the neural elements that are there in the spinal ganglion, if they are damaged, there will be poor speech discrimination. Not only these things, certain other causes like ototoxicity. All these drugs, the quinine, the salicylates, the aminoglycoside antibiotic which we use day in and day out, streptomycin, garamycin, tobramycin, kanamycin, all these aminoglycoside drugs, they are notorious in producing ototoxicity, that is sensorineural hearing loss. Drugs which produce nephrotoxicity also will produce ototoxicity. The nephron is like inner ear. Not only that, the various diuretics, especially the ethacrynic acid and fusimide, and certain anti-epileptic drugs, beta blockers, and certain cytotoxic drugs like methotrexate or cyclophosphamide, they are notorious in producing ototoxicity. So whenever you are using these drugs, you should keep in mind of hearing loss, periodically assess them. If there is hearing loss and if there is worsening of hearing loss, you immediately have to stop the drug. Not only that, the topical medication also one should keep in mind. There is no proof that the topical ear drops which we use will give rise to hearing loss. But the chlorhexidine drug which we use during surgery, definitely it will have an impact on the hearing. And not only that, I came across one individual to whom gentamicin ointment was applied topically for burns, he developed hearing loss. And the very common condition, that is otosclerosis, also very notorious in producing sensory hearing loss, especially the mixed hearing loss. Occasionally, in families where the otosclerosis is predominant, you may find pure cochlear otosclerosis also, where there will be pure sensory hearing loss. Next is the Meniere's disease. What is Meniere's disease? It is a disease characterized by episodic vertigo, fluctuating hearing loss, and vertigo in tinnitus, with or without vomiting. So hearing loss is very characteristically sensory neural. The peculiar feature of Meniere's disease is lower tones are more affected than higher tones, especially in the initial stage. And trauma, whenever there is a fracture of the temporal bone, especially the transverse fractures of the temporal bone, they invariably give rise to sensory neural hearing loss. And you should not forget about perilymph leaks after trauma or after surgery, especially stapedectomy, will always produce sensory hearing loss. And last but not the least, the Page's disease, which is characterized by brittle bones, may also produce sensory neural hearing loss. There is one important entity called sudden idiopathic sensory neural hearing loss. They should be all right. You will get up from the bed. Suddenly, you will notice that there will be hearing loss on both sides. Usually on one side. What is the etiology? Exact etiology, we don't know. That is why we call it as idiopathic sensory neural hearing loss. So, if it occurs for higher frequencies, the prognosis will be less favorable. And if patient doesn't recover within 3 weeks, either with treatment or without treatment, he may not recover his hearing. One should keep in mind bleeding into acoustic neuroma tumor, sometimes perilymph leaks, they have to be kept in mind and they have to be excluded. And patient should be immediately hospitalized and treated with low molecular weight dextron. It will improve the blood supply to the labyrinth by lessening the sledging of blood. And best treatment is vasodilatation by means of inhalation of 5% carbon dioxide with air, and steroid treatment is the treatment of choice. And yesterday I was hearing to one Professor Hamid Jalisian from United States of America. He was talking on a subject called autological migraine. According to him, this migraine have certain autological features like pain in the ear and neck stiffness, especially unilateral neck stiffness, sometimes tinnitus and hearing loss, particularly sudden idiopathic sensory neural hearing loss. He was mentioning migraine is a very important cause of this factor, and patients should be treated with anti-migraine drugs. Now, how do we manage these sensory neural loss, hearing loss individuals? So, in most occasions, the treatment is empirical, symptomatic. That means you should treat by reassuring the individual and treat with vitamins, minerals, and antioxidants, so that the nerve is fortified. For rehabilitation, we have to use what is known as hearing aids. So hearing aid, this is a conventional hearing aid. This has got a microphone, amplifier, and receiver. This amplifier and receiver, they are body worn. They are worn on the body, and this microphone is worn in the ear. So there will be a wire running from the ear to the hearing aid. This is conventional hearing aid. But now there are a lot of developments. They are hardly seen. There are what is known as BTE, that is behind the ear hearing aid, or CAC, that is hearing aid in the canal hearing aids, ITC, that is in the canal hearing aids. They are hardly visible. I've shown you in the last class, the former president of United States, Bill Clinton, used to have hearing aids in both ears. Nobody knows. So the hearing aid technology has gone to such a great level, but they are best in speech frequencies. The speech frequency is 250 to 400 hertz. So this range is very important for understanding speech. But as per the amplification, it also amplifies the extraneous sounds, extraneous noises. So that will produce disturbance to the patient. Slowly the patient will get adjusted to this, like a normal person ignores the extraneous noise and tries to understand speech, concentrate on hearing speech. The hearing aid user also, slowly he will get to use this. And the hearing aids, they must be adjusted, tuned as per the frequency loss. And recruitment phenomenon is already there for the patient. So sometimes patient will not be able to tolerate a hearing aid. And certain latest hearing aids, they have got the automatic voice control. That is, whenever the patient speaks, it should not be the patient will be able to hear his voice, so he can modulate his voice, he will not shout. Now, suppose the patient is, as I mentioned already, patient will not be benefited sometimes by the hearing aids. The benefit may be marginal, sometimes even counterproductive. A sensory neural hearing loss individual, sometimes he will not tolerate a hearing aid, and he will say hearing aid is not of any use to me, and he will refuse to use a hearing aid. Even the most powerful hearing aid are not useful for certain individuals suffering from sensory neural loss. Then what is the answer? Cochlear implant is the answer. The implant which you see here is the cochlear implant. To be more precise, this is the external component of the cochlear implant. There is another component, that is internal component, which is surgically implanted in the ear. That is the internal component. This is the external component. External component has got a speech processor here and a microphone which receives the sounds, and it is made, the speech processor will alter the sounds that are heard into electrical energy, and it is carried through this into the wire, into the this is called transmitter. This is called transmitter. This transmitter is worn by the patient, and this transmitter has got a magnet. Through magnet, the internal component and external component are attached to each other, and the sound vibrations in the form of electrical impulses, they are carried into the ear through the implanted inner component. So this is the picture of the ear where the cochlear implant is it is inserted. This particular implant will have an electrode array which is implanted through round window into the cochlea. There is another electrode called ball electrode which is inserted into the temporalis muscle. It acts like an earth, and this is the receiver stimulator package. We call it as receiver stimulated package. It has got a transmitter coil, and the patient will be using a external speech processor, which I have already mentioned. And these are the components of the inserted internal component of the cochlear implant. It has got two electrodes. First is electrode array, which is very, very important, and this is the component which we insert into the cochlea, whereas this is the ball electrode which we insert into the underneath the temporalis muscle, and this is the receiver stimulator package having antenna and magnet and the actual receiver stimulator with electrodes. Now, what are the indications? Who are the candidates for cochlear implant surgery? As far as adults are concerned, any adult who is older than 18 years, there is no limitation of age as such. Bilateral, severe to profound sensory neural hearing loss of more than 70 decibels or greater with little or no benefit from a hearing aid. The patient should be psychologically stable, and there should not be any anatomical contraindications. That means the external ear should be well formed, so that in the middle ear and inner ear, they should not have any deformities. Of course, the inner ear deformities, certain deformities, even though they are difficult to operate, it is not impossible, slightly different. And there should not be any general medical problem like uncontrolled diabetes, uncontrolled hypertension, or any cardiac problems, or severe neurological problems, psychological problems. They should not be there. As far as children are concerned, cochlear implantation is of immense value, because unless we rehabilitate the hearing in children, they will not develop speech. Unless there is hearing and speech, the patient will not develop his mental faculty. So, any child 12 months or older Even less than that, 8 months we are operating, and if there is bilateral severe to profound sensory hearing loss, uh, it is a candidate for cochlear implantation. Thank God, the government of Andhra Pradesh has introduced this particular surgery into Arogyasri for the first time in the country. So, a lot of children are being benefited, and many states, even the central government, has followed the Andhra Pradesh state government as far as the cochlear implantation is concerned. And there is no appreciable benefit with the hearing aids. He is a candidate for some cochlear implantation, and he must be able to tolerate wearing a hearing aid, so that patient is tuned to wear a hearing aid, child is tuned to wear a hearing aid. And patients also should be enrolled into oral education and oral education program, because the hearing, doing a cochlear implant surgery is not the end of the program. In fact, the whole importance starts from the surgery. Once the surgery is done, patient should be subjected for what is known as auditory verbal therapy. The audiologist or speech pathologist will take over the patient and start training the child. There should not be any medical or anatomical contraindications, like just like an adult, and the parents should be motivated. And here is the patient who is a child. The parents should understand the program. They should have realistic expectations. That is, what is the difficulty? What is the surgery? How the surgery is being held? How you have to act after surgery? What are your responsibilities? Parents should be clearly understanding. And let me remind you again, meningitis is a speech and hearing emergency. If you neglect meningitis, the labyrinth will be replaced by bone because of the labyrinthitis ossificans. So once meningitis is there and recovers from the illness, he has to thoroughly evaluate for hearing loss, and cochlear implantation should be planned. Now the contraindications are incomplete hearing loss and neurofibromatosis too. Once there is neurofibromatosis, there is no properly functioning auditory nerve, so cochlear implantation may not help. And mental retardation, psychosis, organic brain dysfunction, and unrealistic expectations of the parents, they are all contraindications. If there is active middle ear disease, say chronic suppurative otitis media, you cannot operate unless you treat the chronic suppurative otitis media, either by medicine or by surgery. CT findings which suggest Michael deformity. This is Michael aplasia. There is aplasia of the inner ear, and there will be aplasia of the eighth nerve. You cannot do cochlear implantation. Only you have to do what is known as ABI, that is auditory based on implant. And dysplasia not a necessarily contraindication. That is mondary dysplasia. Here you will have only, instead of 2.5 tons of cochlea, you may have only 1.5 tons. And there may be a large vestibular aqueduct. There are relative contraindications. And if there is canal wall down mastectomy, again it is a relative contraindication, and the patient should be treated differently. And labyrinthitis ossificans, very difficult to operate. You may have to need a cochlear drill out procedure and a shorter electrode. And advanced otosclerosis also, it is not a total contraindication, but it is a relative contraindication, because the implant will stimulate the facial nerve sometimes. So you may have to inactivate a few electrodes after surgery. So a thorough audiological examination has to be done so that there is binaural amplification, and a CT scan MRI should be done. There must be a fluid-filled cochlea and a functioning auditory nerve. They are the indication, they are the requisites for cochlear implantation. And as we already mentioned, patients should be well versed in using a hearing aid, and there must be psychological evaluation. This is very important, and medical evaluation. This is also very important, and all necessary investigations should be done to know the etiology of the hearing loss, and we have to give a pneumococcal vaccine to prevent meningitis postoperative. And this is the surgical technique. So this electrode array, 22 electrode array, will be introduced into the round window, through round window into the basal term of the cochlea. This is by means of what is known as posterior tympanotomy approach. Now let us try to demonstrate the video. This is the procedure like mastectomy. First cortical mastectomy is done, just like any other surgery, any other mastectomy. This is the auditus addentrum. Now we will make a small opening that is called posterior tympanotomy. We identify the sharp incus. This is the sharp processus. Sharp processus will be pointing towards the facial nerve. So we have to identify the facial recess by means of the what is known as caudofacial angle. Identify the caudotympany and facial nerve. We have to open the middle ear cavity carefully without damaging or hurting the facial nerve down. See, we are trying to identify the round window through this opening. This is the round window notch, round window niche. It is filling the round window niche so that round window is fully coming into view. Once round window has come into the view, this is the array which I was talking about. It is very, very gently introduced by means of the forceps. This is called watchmaker's forceps. Gently we introduce without damaging the inner ear structures. The receiver package which I was talking about is already implanted, and it is secured by means of sutures. We prepare a bony well. Into the bony well, the receiver package is introduced and secured. And the opening which we made in the posterior bony metal wall is closed by means of a small piece of periosteum.
This is an instructional video outlining the indications and surgical steps of cochlear implantation in a 6-month-old child. Currently, cochlear implantation is approved by the FDA for children over the age of 1. However, many centers are now implanting at a younger age, understanding that earlier access to sound through bilateral simultaneous cochlear implantation provides improved speech and language development outcomes. The labeling criteria for cochlear implantation in children vary according to age as well as manufacturer. All children should have a hearing aid trial of at least 3 months to demonstrate non-benefit before considering cochlear implantation. For very young children, behavioral testing in combination with DPOAE and ABR should be used to confirm severe to profound sensory hearing loss. Additional information can be obtained through parental questionnaires such as the ITMACE and Little Ears.
As I mentioned,
in addition to audiometric candidacy, medical candidacy must be evaluated. The initial evaluation typically involves obtaining a CT scan and MRI, in addition to an ophthalmological evaluation, EKG, and potentially genetic testing. The MRI provides valuable data regarding the shape and morphology of the inner ear, in addition to the status of the cochlear nerve, whether it is present, hypoplastic, or absent. The CT scan provides complementing information regarding inner ear morphology, but also allows the surgeon to evaluate the course of the facial nerve, which may be aberrant, particularly in patients with labyrinthine malformations. Currently, in the United States, cochlear implantation is not usually pursued until after 6 months of age. Most commonly, bilateral simultaneous cochlear implantation is performed. By 6 months, the child is generally old enough to withstand general anesthesia with very low risk. In addition, this provides the surgeon and the audiology team to obtain good information and proof of deafness before proceeding. This is a right ear in a 6-month-old child who has been found to have profound hearing loss.
All of them.
A line is marked to demonstrate the trajectory of the future receiver stimulator device. This should be matched for symmetry when performing bilateral simultaneous cochlear implantation. Next, a line for the postauricular incision is marked, generally at least half a centimeter or more from the postauricular sulcus. In infant and pediatric CI, I prefer to make a smaller incision to reduce pain and allow for faster healing. Here, a 3-centimeter incision is marked. This is just large enough to receive the device. A smaller incision is facilitated by use of the tight subperiosteal technique, as will be discussed later.
The results are excellent, and oral education is most important.
A pre-injection was already performed. It's important to ensure the patient does not exceed the maximum allowable dose of lidocaine.
Coming back to the other types of hearing loss.
The incision is made through skin and subcutaneous tissue after palpating the mastoid tip.
Non-organic hearing loss may be psychogenic hearing loss, otherwise known as functional hearing loss.
The incision is then staggered or stair-stepped forward for the future musculoperiosteal incision. Staggering the incision reduces the risk of implant exposure in the very unlikely event of an infection or dehiscence.
Serial audiograms, and you can do an electrocochleogram to confirm or rule out psychogenic hearing loss. And malingering is also very important situation where you have to identify the malingerer.
Younger children have a lower intravascular volume reserve, and therefore meticulous hemostasis should be obtained throughout the case, both in soft tissue work and during bone work. Electrocautery is used on a low setting, taking care to avoid the region of the mastoid tip.
Vibrate a tuning fork and bring nearer to the ear.
Next, the musculoperiosteal layer is elevated forward until the ear canal is encountered. Additional posterior elevation is required to expose the mastoid cortex.
Patient says he is not able to hear well on the left ear. You vibrate the tuning fork, 2 tuning forks, put on both sides of the ear, and bring into the nearer to the ears, especially the left ear. Then he will say, I'm not able to hear. But in fact,
Self-retaining retractors are then placed.
Hear the tuning fork that is nearer the ear, not the tuning fork which is away from the ear. That is how you will identify the billing error. Next test is steel test. In steel test, if the patient admits that if a tuning fork is kept on the bone, he is able to hear. If you keep a tuning fork by the side of the ear, he says, I am not able to hear. Now, you take a tuning fork and you take another tuning fork and put without vibrating on the
Next, a cortical mastoidectomy is performed. Pediatric and in particular infant bone is very soft, and care should be taken not to expose the dura. Particularly in very young children, pneumatization of the mastoid bone is not complete, and there is often marrow present throughout the mastoid space, particularly near the tip.
Then you put the
Switching to a diamond burr early after removing the mastoid cortex facilitates hemostasis when drilling through the marrow regions.
Then patient says,
just as with adult mastoidectomy and pediatric mastoidectomy, drilling usually begins along the temporal line and the posterior ear canal. Particularly relevant for cochlear implantation, the posterior bony ear canal must be thinned.
Next is the lumbar test. That is,
thinning the ear canal improves illumination and also brings you to the facial recess. Similar to with adult mastoidectomy, during pediatric mastoidectomy, it's not uncommon to encounter a prominent Kerner's septum or a false bottom of the mastoid cavity.
It is taken care of by testing the Beningrat by lumbar test. That is, you take a vernish
as seen
box
here, removing the final layer of
here
Kerner's septum brings you to the mastoid
ask the
antrum.
patient to read something. If patient is really deaf, he will raise his voice while reading. If the patient is a Beningrat,
again, using a diamond drill facilitates hemostasis in areas with marrow.
Another test is delayed speech feedback. Same principle like lumbar test. You have to have a tape recorder and a playback system. Once you record his speech and then you play back his speech into the so-called deaf ear.
After identifying the lateral semicircular canal, the first major landmark in mastoidectomy, the ear canal is thinned further and the incus is identified.
A patient who is really deaf, he cannot read normally. And the stapedial reflex test should be done. In the case of a Beningrat, stapedial reflex will not be.
In all cases of mastoidectomy, it's good practice to avoid drilling on the incus.
If the patient is really hearing loss, stapedial reflex will not be there. And
here, the incus can be seen in the mastoid antrum.
Response audiometry will give actual hearing level.
At this point, it's helpful to review relevant surgical landmarks. The lateral semicircular canal, the posterior bony ear canal, the tegmen, the incus.
This will give the correct reading. This is how we can demonstrate it.
And also the second genu of the facial nerve.
Thank you.
The lateral semicircular canal and the incus provide the most important landmarks for the facial recess. The facial recess is outlined by the facial nerve posteriorly, the chordae tympani anteriorly, and the point at which the incus attaches to the incus buttress is the widest portion in the triangle of the facial recess. Opening the facial recess begins with a 2-diamond drill and continuous irrigation. The strokes of the drill should be parallel to the course of the facial nerve. In some cases, these air cells are helpful because they give the surgeon a clue as to the location of the facial recess, but they also may expose the facial nerve or other important anatomy. While drilling the facial recess, the goal is to access the middle ear space without uncovering the facial nerve or injuring the chordae tympani nerve. While drilling the facial recess, it's not uncommon to have to switch to a smaller drill size, perhaps a 1.5 or a 1 diamond drill, while drilling the inferior aspect of the facial recess near the area where the chordae tympani nerve and the facial nerve come together. Here, the round window niche can be seen. It's important to gain adequate exposure when drilling the facial recess, not only so that the surgeon can visualize all